So Dr. Angela George is the Clinical Director of Genomics at Royal Marsden. She's driving the large-scale uptake, the clinical uptake of genomics through many large-scale programs, both locally in the UK and Europe. She chairs molecular tumour boards, leads numerous international clinical trials. And yeah, I'm really looking forward to your talk, Angela. So thank you very much.
No problem. So thank you for letting me speak. I'm just going to talk a little bit about some of the programs that we've been setting up in the UK and how COVID has been both a help and hindrance to driving some of these things forward. So I think it's fair to say that neither New Zealand or Australia can learn much from this chap, who obviously has been driving what can only be described as a catastrophic response to COVID over the last little while, in response to those who have clear communication. And COVID has obviously been a massive problem for us since essentially early March and then late March when we went into lockdown, which caused just a complete standstill of all of our normal health services in the UK. So a little bit about the background of what's been going on in genomics in the last little while over here. So essentially for the last 3 years now, we have been undergoing a wide-scale alteration of genomic services in the UK, whereby NHS England, who's our major funding body, made the decision to reduce and consolidate all genomic testing in the UK into 7 hubs around the country. And I should point out this is just for England. The devolved nations, Wales, Scotland and Northern Ireland have been allowed to continue with their own programs. But the idea with this was that we would end up with 7 large hubs around the country who were able to provide rapid turnaround times and large panel testing for all patients, so that we would suddenly begin to develop a large database of genomic variants and we'd be able to drive research and trial recruitment for all of these patients. And in order to do this, obviously it was necessary to cut down the number of laboratories. I think at the time at which this started, there were 27 laboratories around the UK providing some level of germline testing, and around about 30 laboratories around the UK providing some level of somatic testing. And the difficulty with that was that there was huge variability around the country. There was very different commissioning around the country as to which patients got which testing. There was actually no official funding for somatic testing whatsoever, and the germline was very hit and miss. So the idea was that as part of this, we would be driving personalised medicine. We would be trying to get a similar number of large panels across the country to get all of the additional information rather than just 2 or 3 genes for each patient. And in order to do this, they decided that they would develop the first ever test directories across the country, whereby there would be a national database. If your patient met the criteria in the test directory, they would be able to get a centrally funded test no matter where in the country they were, with the idea that this would be updated regularly to reflect new developments, new drug approvals, etc., so that it was meant to be relatively responsive. And these were the aims of the service as they were set up. You can see that it's relatively aspirational. They were looking really to be able to provide a whole host of clinical and research outcomes. They were looking at partnerships with industry and academia and the ability to really provide a world-class genomic service, which is probably not something that we would have described our genomic service as previously. As I said, we have national test directories, whereby we have a rare disease directory, which includes eligibility criteria for all testing. And interestingly, we've moving to a mainstream model across multiple different disease types. We've been doing mainstream testing for certain groups of cancer patients for a long time, whereby the patients could access germline genetic testing through their oncology service, but we now have similar tests available in neurology, cardiology, endocrine, respiratory, etc. So for every test, it describes the criteria that the patient had to meet in terms of their diagnosis or age at diagnosis or family history, and then also who was able to provide the test, such as their cardiologist or a clinical genetic service or pediatrician, etc. As I said, we also have a cancer test directory for our somatic testing, which again is the first time that there has ever been a national consensus about which tests should be offered. So again, you can come to the test directory, see if your colorectal cancer patient is a new diagnosis, the somatic tests that they are now eligible for, and where you can access these. As I said, the biggest thing here has been centralised funding. So the idea is that the testing is provided in one of the hub labs. We all had to bid to become a hub lab, and then the patient's test is sent to us, and NHS England pays us directly. So it no longer goes through the hospitals or the different genetic services. Now, the centralised funding was due to start from the 1st of April. Of course, COVID hit us quite heavily in March, and so the centralised funding has been slightly delayed, but the test directories have gone ahead. Along with the large panel testing, they have also set up a national diagnostic whole genome sequencing service, and this comes off the back of the 100,000 genomes program that we ran for the last few years in the research setting. But we now have a list of tumour types or conditions for which patients will be able to access a diagnostic whole genome as their genomic test of choice. Now, again, this was due to have started by now, but that has also been put on hold because of COVID, and because of course a lot of the laboratories around the country were switched onto testing for COVID samples. So this is now the whole diagnostic whole genome sequencing service is now expected to start later in this year. As I said, COVID has brought us a lot of changes, and whilst I don't think any of us are enjoying the new normal, and we had complete shutdown of many services for months, we have had a few bonuses, and we have had some innovations that have come through which have actually been incredibly helpful. I guess one of the things about the NHS is that it is a really large, unwieldy service, and it takes a long time for new innovations to get approved in normal practice. But COVID has definitely escalated some new approvals. So, for example, we now have a compassionate use of drugs which are considered to be less immunosuppressive than chemotherapy. So, for example, in my specialty of gynae, we've just been able to get an oral MEK inhibitor for our low-grade serous ovarian cancers, which was not previously funded or approved. We have suddenly got access to immunotherapy for our mismatch repair deficient tumours across the board, which again was not something that we had routinely before. And we've developed a lot of innovations for our patients who are not willing or able to travel into the hospital. One of them has been the Attend Anywhere service, whereby instead of coming into the hospital, patients get sent a URL number for their appointment. They just click on the URL and they're taken directly into the doctor's waiting room. And then when I'm doing my clinic, I can see the patients that are waiting, click on them, and the patient is there waiting for me to start talking to. And the patients can also share the URL with their family members. So you can end up doing what looks a little bit like the Zoom call sometimes with a whole host of family members who are scattered around the country, so that they can all take part in the appointment, which is something that just really, under normal circumstances, would probably have taken years to get through the NHS. But there have been a number of real problems with oncology and genomic services. And so from late March, the hospitals went into crisis mode, as I said. A lot of routine service stopped, including routine outpatients and investigations. And in order to do this, this was mostly so that they could set up expanded ITUs and HDUs, and a lot of things like day surgery units and scope units were repositioned into HDUs. All of our clinical trials were suspended, so we weren't allowed to set up any new trials or recruit any new patients into trials, although those who were already on trial were allowed to continue if it was considered in their best interests. And there were 2 cancer hubs set up across London and a couple set up across the rest of the country, so that cancer patients who required urgent surgery that was defined as must be undertaken within 24 hours or within a couple of weeks were allowed to continue, because most places had to stop routine surgery because of the need for the ITU beds for COVID patients. So we were one of the cancer hubs. We started taking cancer surgery from across much of London, partly because we don't have an A&E here, so we didn't have that constant influx of COVID patients coming through. But there was a massive issue with patients being diagnosed. So for example, most patients weren't getting surgery unless there was no other treatment for them. So for example, if patients were suitable for neoadjuvant chemotherapy or hormone treatment, they would be started on that rather than go straight to surgery. There were very few diagnostic services, so no one was undertaking bronchoscopy, colonoscopy, or gastroscopy. So getting tissue for a biopsy and genomic information was extremely difficult. And interventional radiology was generally only taking image-guided biopsies in patients with a malignancy that was deemed curable. So again, most tumor types were not able to access image-guided biopsies either through this time. So into our hub lab, so we're the hub lab for North East and West London for all cancer samples. We had a 30% reduction in samples from our hospital, and keep in mind we were one of the few that was still running surgery and interventional radiology. And most of the cancer centres around London had a reduction of over 90% of new diagnoses through the 4 months of our major lockdown. So we then had to look at how we could adapt to oncology with minimal or no tissue for genomic testing. And so this is when we started looking more closely at routine use of CTDNA. So CTDNA is really only being used in the research setting in the NHS routinely. It is approved for EGFR testing in lung cancer, but everything else essentially is not approved in the NHS. We were lucky that we had several in-house CTDNA tests, which we have validation been using for some time, including in some of our breast studies in our paediatric panel. We also had one that we had worked up to focus predominantly on lung patients. And we were able to convince Guardant to give us a number of free tests for compassionate access so that we could start running these on patients with suspected lung cancer in the first instance to see if we could find any targetable mutations which would allow these patients to begin treatment rather than having to wait until someone could get some tissue off them to undertake further testing. And this proved actually to be very successful. So as a result of running this, we ran our own in-house CTDNA panel alongside the Guardant as an internal validation. And because our test is obviously about 1/10 of the price of Guardant, so if we were looking at using it in a more wide scale thing, Guardant was just not affordable to us. And we were able to both internally validate our own test, but also find a number of patients we could then immediately start on their treatment with a targeted agent. So we had patients starting crizotinib, a lot of patients on EGFR inhibitors, and so forth as a result of being able to use this. And we subsequently started using it in some of the other patients who looked to have more advanced disease where we were unable to get tissue either because they couldn't undergo the scope that was required and they didn't meet the criteria of being curable for interventional radiology. So as a result, across several different tumour types, we were able to again undertake genomic profiling using one of our CTDNA panels, which gave us an idea of a diagnosis, and then we could start treatment on these patients. We've just submitted a couple of abstracts based on some of this work, and we have also just presented it to NHS England. So they are in the midst of reviewing some of our information to see whether or not they will approve our internal CTDNA panel onto the test directory so that other hubs and hospitals across the country are able to access this as we go forward in what is almost certainly our next wave of COVID just starting over here. So essentially this is just us trying to look at every possible way to get a diagnosis and get patients started on treatment when we don't have any other options for them. I'm going to stop at that point and